member for the past 3 years now. I did my fellowship with Dr. Madan Balal at Sanjay Gandhi Hospital, after which I did my shoulder fellowship in South Korea. And then I did subsequent stints in Germany and France for a month each. So 3 years now.
Akshay, we are live. Akshay, we are live. I think we'll allow Terence to take over.
So good evening, everybody. We are on the this month's webinar. We have eminent speakers, and including our IAS President and Secretary, Dr. Sundarajan sir. Would you like to start off by giving a welcome message?
Yeah. Good evening, everyone. On behalf of Indian Arthroscopy Society and our Dynamic Secretary, Dr. Raju Raman, I welcome you all for this webinar. And we have a wonderful speakers today, where we have a past President IPS Oberoi, and we have some case presentation from Dr. Sugail and Akshay. And also, I'm happy to see the moderators are an high-level moderator today, Prathamesh and Shyam Sundar from Coimbatore, who are coordinating this program. Okay, without much ado, I hand over to moderator, Dr. Prathamesh Jain, to continue the program.
Thank you, Sundar sir. Thanks a lot. So I would not take much of your time, and I'll be introducing Dr. Suhail Sheikh. He is a upcoming arthroscopic surgeon from Pune. He's practicing in Pune, and I'll not take much of the time. He's practicing in the Ruby Hall Hospital, and I'll just invite him to present his talk. Dr. Suhail.
Yes, sir. I'll start first.
Yes, sure. Go ahead.
Sure. Is my screen visible to everyone?
Yes, we can see you. We can
see
you. Yes.
We can see you very nice.
All right. So, good evening, all. Thank you for this opportunity. I'll be speaking on the retracted subscapular tear, the arthroscopic management. Now, as you know, the subscapularis is the largest and the strongest muscle of the rotator cuff. It is a primary internal rotator of the shoulder, and it also contributes to the anterior shoulder stability. A bit on the anatomy, it originates from the subscapularis fossa and inserts on the lesser tuberosity of the humerus, and it's supplied by the upper and lower subscapular nerve. So the biomechanics, it's a powerful internal rotator. It's also it's a dynamic anterior stabilizer and contributes to force coupling along with the posterior cuff. So types of tears, of subscapular tears, are two types. One is a traumatic, which is caused by a forceful external rotation or a hyperabduction injury. And the degenerative tears are because of chronic tendinosis or subcoracoid impingement or overuse or repetitive stress. So now the most commonly used classification is the Lafosse classification, which divides it into 5 subtypes. The type 1 is an upper third partial tear. Type 2 is an upper third complete tear. Type 3 is an upper two-third tear. In type 4, the entire subscapularis is involved. However, the head is centered and the fatty infiltration is up to 1 to 3 Bouteiller grade. And type 5 has a complete tear with anterior subluxation of the humeral head with a fatty infiltration of grade 4, grade 5. Now, the recent classification was by Yu and Rhee. And the main reason for this classification is because they found that the Lafosse type 1 was quite a heterogeneous group, and there was no subclassification for the partial tears. As a result, it was leading to a clinical treatment dilemma on what to do with the partial tear, whether the patient would be benefited by a surgical management or whether a conservative treatment will be helpful for him. So they divided the type 1 Lafosse into 3 subtypes, like type 1, type 2A, and type B. So type 1 is just a fraying or a longitudinal split at the leading edge of the tendon. The type 2A is a partial tear involving less than 50% of the tendon detachment from the first facet. Type 2B is also a partial tear with more than 50% tendon detachment from the first facet without complete disruption of the lateral band. Type 3 is a full thickness tear of the upper 1/3, representing a complete first facet detachment with lateral disruption. Type 4 tears are involving first 2 facets with medial retraction of the tendon, and type 5 is a massive tear involving the entire subscapularis tendon, infrequently involving the muscular portion. So now type 2B, these have reached a threshold. So according to their classification, the type 2B tears, even though they're not a complete tear, the structural integrity of the tendon has been lost. And according to this classification, patients with type 2B will benefit from a surgical management. Now, for the clinical presentation, generally the patients will present with anterior shoulder pain. They'll have difficulty in internal rotation, and most common, they'll be complaining of difficulty in reaching behind. The clinical tests are the Gerber's lift-off test, the belly press test, bear hug test, and we'll also find an increased external rotation of the shoulder. For imaging, MRI is the gold standard. The axial cuts best demonstrate the tendon retraction. T1 sagittal is helpful to assess muscle atrophy and fatty infiltration. So this is a clinical case. This is a 68-year-old gentleman. He was a right-hand dominant businessman by profession, presented with left shoulder pain after a history of fall from a two-wheeler. Pain has aggravated over the last 6 months. That's when he presented to us. He mainly complained of difficulty in reaching the back when he was trying to tuck in his shirt. He's a known case of diabetes and hypertension, which is on treatment. On clinical examination, his flexion was up to 150 degrees. Abduction was also 150 degrees. External rotation was 45 and internal rotation was only up to the SI joint. Coming to the power, the supraspinatus was 4/5. Resisted external rotation was 5/5. Belly press was positive. Bear hug was positive. And the lift-off test also was positive. So this is his a small video demonstrating his lack of internal rotation. Unfortunately, this is the only bit of video I have of him. We'll just play it again. That's it. He can just reach up to the SI joint. This is his MRI. This is a sagittal sections. So in the upper part of the segment, we can see that the lesser tuberosity is completely bare. A lot of hyperintense signal around it, and there's no muscle which is attached to the lesser tuberosity. As we come further medial, we can see there's some fatty infiltration in the subscapularis, and some amount of atrophy is also present. The supraspinatus and the infra look normal in both. This is the axial view. Here we can see that the subscapularis is completely torn from the lesser tuberosity and is retracted. This is like an upper two-third type of tear. The head is still centered and the biceps is still in its groove. And this is the coronal cuts. In the coronal cuts, the rest of the rotator cuff, the supraspinatus and infra wall found to be normal. So this is just a short surgical video. So I'm generally I do it in the lateral decubitus position. I'm viewing from the posterior portal. I have already done a biceps stenotomy as the tendon was very much inflamed, and I have cleared the rotator interval. I've placed a traction stitch into the subscapularis tendon, and now I'm going about a soft tissue release both on the anterior and the posterior sides of the tendon, as I found the tendon was to be very stiff and was not mobile. So after clearing the articular part, I try to see the mobilization again. And we can still see the tendon is not being approximated back to its footprint. So I try to release it from the bursal side of the anterior part of the tendon while playing. Mobility has somewhat increased compared to what it was previously. However, it's still unable to come back to its footprint. I further went ahead and did a release of the soft tissues around the coracoid. Is my screen visible, sir? Yeah.
Yes.
Yes, we can see you.
Yeah. So I did a
Slides low,
release
but
also.
yes.
And here's the first anchor which I'm placing at the footprint. It's a double loaded peak anchor. After anchor placement, I used an anti-grade suture passing device to take 2 bites from the tendon. The first bite was taken inferiorly. That's the first needle coming out. And the second bite was taken superiorly and medially. I have just taken simple sutures in this case, considering the amount of retraction. I didn't want too much of tension to be there on the repair. So following suture passage, knots were tied in a sliding fashion. Now you can still see that the tendon hasn't been brought back to its anatomical footprint, as that would put a lot of tension on the repair. So the current location is slightly medial to what it should have been. And this is the picture after the repair. So this is this gentleman. Now, this is the video is there after 4 years. He was on holiday, and that's when he sent me this video of his. He's got good forward elevation, complete forward elevation. Good amount of abduction as well. I'm sure he can take it higher than that. And this is the amount of internal rotation. Yeah. So he's pretty happy at the moment. 4 years post-op. Coming to the conclusion. So my post-op protocol, I generally keep them in a shoulder sling for a month. I start wrist and elbow flexion extension exercises from the first post-op day, along with shoulder shrugs, pendulum exercises, and I allow assisted arm elevation within pain tolerance up to a level of 90 degrees only. After a month, the assisted arm elevation is extended beyond 90 up to pain tolerance. We start with table slides, pain exercises, and strengthening exercises in the form of band are started at 8. So this is my short surgical video on a subscapularis repair. Thank you, sir. Thank you for your kind attention.
Excellent. Good, Doctor. Very
Yes,
nice,
sir.
very nice, Dr. Sohail.
Thank you, sir.
Very nice. Nice presentation. So, any time in your technique you want to go through the supraspinatus if the supraspinatus is torn?
So if the supraspinatus is torn and retracted, it gives you better exposure. In this case, the supraspinatus was intact. So I have generally, this was the first subscap repair I was doing. And this was done 4 years back. So I have done an inside the box technique. And that's the one which I had learned during my fellowship under Dr. Ram Chidambaram. So I've just used an inside the box.
You executed it very well.
So thank you, sir.
Pleasure.
Dr. Sohail, just a basic question. What is your tips and tricks to identify subscapularis tear which nearly looks normal? What are the secondary arthroscopic signs you would think about to advise, have high suspicion
So,
of
in many cases, in cases of the partial tears especially, this was a retracted tear easily spotted. But there's this comma sign, and I feel that you should put a grasper and try to pull the tendon up. That's where you can really identify the extent of the lesion. So grasping it and just checking for the mobility, that will help.
One more addition, which I would always consider, is looking at the integrity or the orientation of the MGHL. If you're not able to see the MGHL as normally as you would, then you have to have a high index of suspicion with respect to subscapularis tear.
All right.
Another most important thing is to check for the sentinel sign, which is nothing but derangement in the structure of the longet of biceps, which in turn indicates there is some sort of an instability which is happening within the biceps due to the loss of either the medial pulley or the lateral pulley. Most commonly, it is the medial pulley due to the subscapularis partial tear. So these two signs are the other additional things which you need to have a look at.
All right.
To have a high index of suspicion with respect to a subscap tear. Thank you.
All right. I'll keep that in mind. Yeah.
Sir, Shyam sir, that was an excellent question. Actually, even I was thinking of asking the same to Dr. Sohail also. I think when you begin your shoulder scopy, it's subscap tears are very difficult to identify. You know,
It is. Yeah.
it looks absolutely normal when you go and put your scope there and see it looks normal. Only when you just lift, forward flex it a little bit and then you internally rotate, then you see that lift off there. And as Shyam sir rightly pointed out, that MGHL, if it is not in that position, vertical position, and it looks as if it's fallen down, that is also an indicator for identifying the tear for all the sake of the beginners. So I think excellent presentation, Dr. Sohail Sheikh.
Thank you, sir.
Very nice.
Thank you.
Excellent. Excellent, Suhail.
Thank you, sir.
I think subscapularis isolated tear are uncommon. And you have managed it very well, because there's a retracted tendon. Sometimes it's very difficult to bring it back to footprint. I think you have managed well with one double loaded anchor with medialized without tension. That has done the trick to balance the shoulder and is able to bring back the rotation. Well done.
Sure. Thank you, sir.
Dr. Sohail, we have one query from our YouTube viewers.
Yes, sir.
They are just asking about the routine, the standard portals that you use for subscap, the viewing portal and the working portal, and the position of the limb to identify that tear, and also, when you're taking your knots and other things, especially when you're doing inside out, inside the box kind of a repair.
So the viewing portal was the standard posterior portal, and I had made two anterior portals. One and through which I was passing the suture and I was shuttling into the other side. So one was an anterior and one was slightly an anterior superior portal.
Right. Thank you. Thank you, Dr. Sohail.
Thank you, sir.
I think
You are muted.
Yeah, sorry. Dr. Prathamesh, sir, would you like to introduce our expert speaker for today?
Yes. So the next
the topic is 270-degree labral tear. So
70 degrees.
Please, please go ahead.
So I am glad to announce Dr. Akshay. He is a consultant at Manipal Hospital, Jayanagar.
Sir, Dr. IPS sir is ready with the presentation.
Dr. IPS is doing okay, sir.
Yes,
okay,
yes.
So Dr. IPS sir needs no introduction. Everybody knows him. So I would like to welcome IPS Oberoi sir. He's one of the gems in the field of arthroscopy, and we all love him. So inviting Dr. IPS Oberoi for the posterior labral talk.
Thank you very much, Sundar. Thank you, Dr. Rajiv Raman. Thank you, Prathamesh. Sohail, it was a wonderful presentation. Very nice to see. It's nice to see Shyam back here again. So I think that's a good platform for us to talk. So I'm just showing a small presentation. It's a shoulder case of a 270-degree labrum tear. So I think these labrum tears are something which are a bit more uncommon in our practice. And it is.
Sir, are you able to see the screen?
Yeah, I am able to see, but can we make it larger? We can see it.
Can you see it now?
Yeah, I can see. So is everybody able to see?
Yes, sir.
Yeah, perfect.
Because of
Yeah, we can see it, Terence. We can see it.
We can see it well, sir.
Yeah.
So I think let's start the presentation, Terence. So this is a national cricketer. He's a 23-year-old male. He's an all-rounder. So he bowls well. He actually bats very well. He's got a pain in the right shoulder after recurrent injuries. This guy is unable to bat now. His throwing has become very, very poor. And he says that he's got a crepitus in his shoulder. When we examine him, his shoulder translates both anteriorly and posteriorly more than what the normal shoulder would do. And he's a bit more hyperlax. It's around 7 out of 9, the Beighton's criteria. That's his examination. If you see, he got an external rotation which is much more higher. but he's got a very high internal rotation as well. So this is a quite lax joint on clinical examination. Let's go to the MRI as the next slide. If you see the MRI on the next slide now, there is a damage to the anterior labrum. There is a damage to the posterior labrum. And in the next slide, we can see there is also a damage to the superior labrum. So here. So if you see here, these kind of labral tears are actually involving all the circumference of the shoulder. So next slide. And this tears are called as 270 degrees labrum tear. So that's an arthroscopic picture how these labrum tears are visible. So we come into the intercondylar notch, come down. Here if you can see, that's the anterior labrum. I am swiping down, that's the axillary fossa, and right back also is the posterior labrum tear. So this labrum tear is essentially involving the posterior labrum, inferior labrum, anterior labrum, and also superior labrum. So the circumference essentially involves 370 degrees. This makes shoulder quite hyperlax and mobile, and the patient has got crepitus and is unable to throw because the humeral head is unable to centralize on the center of glenoid. And this kind of extensive labral tears are quite known, pretty well known in those who are involved in explosive sports, especially basketball, volleyball, as well as cricket. So if you look here, that's a global shoulder tear where involvement is anteriorly, inferiorly, as well as posteriorly, and also superiorly. Okay, let's go to the next slide now. So this is the diagnostic show how exactly these kind of labral tears do happen. So it can happen which involves the superior labrum, anterior, inferior, and posterior. It could also start from posterior superior, going all the posterior down and anterior. So if you look into the circumference here, these are called 270 degree labral tears. Next slide, please.
1 second, sir.
Yeah, no worries. Now to do a 270 degree labral repair, in addition to your three portals which we make, the posterior portal, the anterior midglenoid portal, and anterior superior portal, we have to make another portal which is at the corner of the posterior border of acromion. So here, which is marked as A. So I think this is an important portal because with this portal, we are able to go down and project our anchors at the posterior. So now instead of three portals, we often end up using four portals when we do a 270 degree labral repair. Next slide. So because now the labrum tear involves the slap tear, it involves the posterior inferior tear, posterior superior, and anterior inferior tears. You can have all these four portals where you can keep on moving from one portal, put the suture anchor and lasso from the other portal, and suture management from the third portal. So if you look at the chart which I made, it makes it very easy. For the slap one, you are actually seeing from the posterior portal. Your portal for the suture lasso is midglenoid, and portal for the anchor is your anterior superior portal. Now you have to swap if you want to do anterior inferior, because your viewing portal now will become anterior superior. Your portal for the suture lasso will be posterior, and suture for your anchor insertion essentially is the accessory posterolateral portal. The portal I was telling you, accessory posterolateral portal. And because you have to now deal with all the four part of the labrum, you have to keep on moving your scope from posterior to anterior superior and your instruments from posterior to anterior. So these four portals help you in managing this kind of 270 degree labrum tear. Next slide. These type of labrum tears have been reported in literature as well. A lot of work has been done by Tokesh. Tokesh is a surgeon, which is an American surgeon, and he deals with almost all American Navy SEALs. And probably in these subgroup of patients, lot of explosive sports and injuries do happen. Ian Lowe as well as Steve Burkhardt also had a big series of 270 degree labral tears, and also they were able to repair these labral tears. Now every surgeon, if you look into the chart, has his own way of operating. Like Tokesh actually starts with posterior tear, then come to anterior, and finally goes to superior. While if you look into Morocco, he starts with posterior, then goes inferior, and then anterior. I think every surgeon has his own preference to do, and I'll show you how exactly I deal with these 270 degrees labral tear. Next slide, please. So to repair these 270 degree labral tears, I think if I just do a posterior labrum first, and then come to repair the anterior labrum, the equilibrium and the focus or of the hammock is actually disturbed. You actually tighten one part more and then you are able to not tighten the other part better. So for me, if I am doing these kind of global shoulder labral tears, I would actually start fixing the posterior one just by a single anchor, come anteriorly by a single anchor, which means once I put an anchor posteriorly and an anteriorly, I'm able to actually pull the PIGHL and AIGHL nearly equally, and so I am able to restore the center of rotation of the humeral head as well as restore the hammock, which is very important. So unlike other surgeons who start with one part of the labrum and just fix that part of the labrum completely and then shift to the second part of the labrum and then go to the third part of the labrum, I essentially operate on these patients which are 270 degree in a sequence where I start with my first posterior one where I'm going to tighten the PIGHL. So that's the first one, and I'm taking a bite into the PIGHL area and posterior inferior labrum, and this is a fiber wire and I'm loading it onto a push lock device and I'm putting it down that in, which is going to tighten the PIGHL. Then instead of continuing with the posterior, I would actually come more anteriorly now. And this is anterior inferior one, which is AIGHL area. So the second anchor bite is in the capsulolabral complex of the anterior inferior one. And again, a tiger wire is then passed through it and a push lock device is put anteriorly. So if I'm able to tighten the PIGHL posteriorly and AIGHL anteriorly, I'm able to restore the center of rotation nicely. So humeral head comes much more central now, and then I can keep on continuing to repair and complete my repair. So once I've done that, I take another bite. This time instead of lasso, I can use a scorpion because the labrum is floating in front of me, and I can fix the anterior inferior labrum down with a second anchor, and then I can come posteriorly as well for my second anchor there, here in the back. Once I've done all of these three, I come to the superior labrum because I think if you tighten both anterior and posterior and finish and then come to superior, sometimes it becomes very difficult for you to do a superior. So instead of doing all the 6 anchors, I would actually do 2 and 3 anchors down, and the fourth one is the superior one. Once I've done the superior one, I come back to posterior one. So I'm going back to the posterior and anterior one and try and fix it. So the sequence is very simple. The sequence essentially involves first restoring the glenoid humeral coordination well, which means centralization well, and then I'm going to complete the repair. So first is the posterior anchor, then the anterior anchor, then the superior anchor, and then I come back to posterior, back to anterior, and back to superior if it is needed. So it is basically posterior, anterior, posterior, anterior, and if need be, second anchor in the superior one. So if you look here, I've already parked 5 anchors in place now. One is in the superior anchors and 2 anchors are down, 2 anteriorly and 2 posteriorly. This helps me in restoring it, the nice capsulohumeral anatomy back and the capsulohumeral complex nicely back into the anatomical position. If there are still some areas, I can add in 1 or 2 more anchors. But if you look here, that is the posterior anterior one, 2 anchors, the apical anchor, third, and 2 posterior anchors. So total 5 anchors in the labrum, which is actually taking care of the posterior labrum, inferior labrum, and anterior labrum, and 1 anchor in the superior. So you end up actually putting 6 anchors when you have a 270 degree labrum tear. Next slide, please. Yeah. Now we do have tensionable anchors, and I think that's the technology which all of the surgeons in instability surgery should follow now. So these are all suture anchors. These are tensionable anchors. If you see here, I can tension my repair. I can pull the suture and I can tension my repair. In a 270 degree repair, it is important to tension the repair as well. So if I use an anchor like push lock, I'm just putting the labrum back as a static. But if I'm using this all suture anchor, the tensionable anchor, I can pull it. So for us, now taking forward for all the instability surgeries, we have shifted from peak anchors and bio anchors to all suture anchors. And in the all suture anchors, these tensionable anchors are best because you can, after putting your anchor and fixing the labrum, you can still tension the anchors well. And that's a technology which is best. Almost all of these patients who had 270 degrees were able to go back into sports, and that's a cricketer which again went back playing Ranjis. Next slide. We have done around 42 of these cases, which are involving 270 developed players. Almost all of them have got high return to sports. Most of the initial surgeries were done by push lock anchors, which are all suture knotless anchors. But now we have shifted to an all suture anchor. And I think taking forward, and I believe whole of the panel of the surgeons on the board today would agree, if you have to put more anchors into glenoid, it is better to put an all suture anchor, because these are very small anchors, 1.6, 1.8 millimeter diameter. They don't take away the bone. And the beauty about these anchors is you can tension them as you keep on fixing them. So these are tensionable or suture anchors. In a global 270 degrees labrum tear, these all suture tensionable technology is one of the technology which is helping us in restoring the bone, putting 6-7 anchors easily, and also tensioning this anchor by end of the surgery. Most of these patients are able to return back into the high level sports, including Ranjis and nationals. Thank you very much.
Thank you. Ripia sir, I have one question. Now, when you, this pan labral tear is not a very common condition that you see, and with your kind of experience, I'm sure doing 42 cases is enormous. But in the clinical perspective, when you come across a patient who is having a pan labral tear, do you follow any specific post-operative protocol? One. Second thing is, how much of movement can you guarantee with these kind of repairs? Because in a classical posterior labral tear or in an anterior labral tear, you're just doing an inferior to superior shift, and you can expect some amount of stiffness, which will gradually get corrected over a period of time. But here, when you have a complete labral tear, actually speaking, you may inherently tend to over tighten because you want to get the capsular laxity to a normal limit. And since it is under control, it varies from surgeons to surgeons. How do you go about with the stiffness? How do we educate the patient post-operatively? What are all the post-operative protocols you follow?
I think, Sham, you've actually pointed out very rightly. If you look into most of these cases, and you might have experience as well of these pan labral tears, most of these tears have a lot of degeneration which has already happened into the joint. So the labrum is not the juicy labrum which we normally see with the Bankart lesion. These patients are involved into high contact sports. Even after getting a labrum tear and subluxation episodes, they don't take your medical help. They actually come back when they become crippled. So they have got a lot of damage both in the cartilage as well as in the labrum, and labrum looks quite degenerate. Their shoulder has got a typical 6-side scapula or scapular dyskinesia, and that's a very huge amount of scapular dyskinesia which is seen in these patients. So I believe exactly what you said, Sham. Rehabilitation is very, very important if they really want to reach to that back level of support. We don't over tighten. There is a tendency to over tighten. If you look into all of these things, anchor repair, you never over tighten these. You just bring the labrum back, because inherently, you know, if you're going to over tighten, this patient is not going to come back into sports. Number two, you're not going to work too much to the superior labrum area, especially posterior superior labrum area. You just put one anchor and that's usually enough. You actually work more anterior inferior and posterior inferior. Rehabilitation essentially involved huge amount of work on capsular stretches and putting the scapula back into the normal anatomical position. If the capsular work and the scapular stabilization is not done, any amount of rehabilitation will not bring these patients back into sports. And I believe exactly what you said. Most of these patients have got very high expectation and they really want to reach to that level. You have to really counsel the patient that they have to go gradually over the period of time. They have to do a lot of these capsular stretching exercises. They have to work a lot on the scapula before really going back into interval throwing and finally into sports. It's a long rehab program which involves between 6 and 9 months. Unlike our anterior instability, which are able to go back into most of throwing by 4th month or 5th month. And these are patients which need to be counseled quite a lot and tell them that even if they want to return back to sports early, they might lose a bit of their rotations by end of the season. So I think that's a point which is a carry home point.
Thank you very much, sir. That's a very valid point. Pre-operative counseling And another thing is continuous post-operative checkup, personalized checkup, because if they lose out on your physiotherapy and they go to some other physiotherapist who has no idea about what has been done, then I think we are his shoulder function is compromised.
Absolutely, Sham, I believe. And I think two of these patients actually had an injection of BioVisc. I mean, I don't usually give too much of visco supplementation, but two of these patients we had to actually inject some kind of lubrication kind of thing. Just psychologically, they feel better because they feel that kind of thing helps. I'm not sure whether it helps or not, but I'm not sure whether any of you are using some kind of visco supplements in shoulder arthritic also, because they've got a lot of chondromalacia as well. So have you or maybe Prathamesh or Sundar, have you used any kind of visco supplements in the shoulder?
No, I don't use it.
So any PRPs or BMAX?
I don't use it.
No. So, Terence,
Sir,
in Ganga, do they use?
no, sir. No,
No,
sir.
no.
No.
Okay. So I know there's no hard evidence right now to use any kind of visco supplements in non-weight bearing joints. Uh, Bhupesh is also joined. I think Bhupesh would have some ideas if he's listening to us. I think Bhupesh is.
Everybody's multitasking, sir.
No. I'm here listening. There was some glitch in my thing.
Okay.
No, sir, I have not used any visco supplementation, but I'm very scared about post-operative stiffness whenever we do the 360-degree labral repair. So, as already both of you mentioned, rehab is very essential, and I specifically see them every time to prevent post-operative stiffness.
Yeah. But sometimes you are surprised because you think it's only an anterior labrum tear, and you go inside and it's usually a global tear. And I think all of you would have experienced this, that you actually went in thinking it's more of an anterior inferior labrum tear, and then suddenly you see there is a element of posterior and sometimes posterior superior labrum tear as well. Isn't it, Sham?
Yes, sir, many times.
90% of the times, the quality of the labrum is really bad, sir.
Really bad, really bad.
So that time you tend to think what is happening to the biological proprioceptors, mechanoceptors, which you've been talking about, which is essential for the rehab. So we have to be having extra responsibility to make sure that the patient comes to you and you have a look at the patient and take care of the patient's physiotherapy. So it's not just a surgery. The post-operative follow-up is extremely crucial for us to return to
Absolutely. Absolutely. Agree. Thank you, guys. Thank you very much.
Thank you, sir. Thank you, sir. So I think we have finished with 2 talks with an expert talk. Dr. Sham, sir?
Yes, Terence. Yeah.
Yes, sir. Would you like to introduce the next speaker, sir?
We have Dr. Akshay Danda, who is a consultant in sports medicine in Manipal, Jayanagar. He has done his fellowship with Dr. Madan Balal, and then he has done fellowship in South Korea. And right now he is practicing as a sports medicine specialist in Manipal Hospital. Welcome, doctor. Please, you can start with the presentation.
Thank you, sir. Thank you. I would like to thank Indian Arthroscopy Society for giving me this opportunity. We're talking about a novel case of ACL augmentation with ramp repair. I had just ran into some technical trouble where my laptop we ran out of charge. So my fellow Dr. Bharat would be playing the slide and I'll be talking about. I hope that's okay. So Dr. Bharat, if we can have the slides. Yes. So thank you all. I'm sure this is a topic of a lot of contention. This was not an easy decision to do, and we debated a lot with the patient and on table and after the surgery as well. But eventually we got a good result with it, so we decided to publish it and present it in front of such a esteemed faculty. And I really would love to hear all of your opinions and what you think about this. So what today's talk is about arthroscopic ACL graft augmentation with fiber tape and a needle-assisted ramp lesion repair. It's a novel graft preserving technique for persistent laxity after primary ACL reconstruction. Next slide, please. So what we find is that a lot of us essentially miss the ramps. In fact, 9 to 24% of the ACL deficient knees have ramp lesions, which we fail to detect. As you can see, the detection rate is 0 to 38%. and less than 50% of identified ramp lesions addressed at the primary surgery. So a missed ramp lesion with a suboptimal tibial tunnel position leads to a compounding biomechanical deficit, which leads to a persistent laxity, causing pain and a lot of issues, mechanical issues for the patient. Next slide, please. So why did we not, think of a full revision? Well, number one, the tibial tunnel, which was a little inferior, which we'll show in the next slide, was not as posterior as, where we could have gone for a single stage revision. The patient was very clear that they did not want a double stage surgery. With revisions, we find that there are inferior clinical outcomes compared to primary reconstructions. Tunnel widening does require bone grafting and stage procedures, and a risk of tunnel convergence with new tunnels is a big issue that can happen. Also, with higher revision rates, with a secondary surgery or revision surgery, the return to sport is lesser and the rehabilitation is much longer. So in our approach, what we did was we preserved the graft and we augmented it anteriorly to the tibia with a fiber tape while addressing the ramp lesion, with all the hope that once we get this stability for both, the patient will recover and get their major functions back. Next slide, please. So this is our case presentation. We present a 22-year-old female, non-athlete. She had a slip and fall in July 2025. The primary surgery was done elsewhere with an ACL and lateral meniscus balancing in September 2025. She presented to us 7 months later with persistent pain, instability, and inability to stand and sit. And when we examined her, she had a positive anterior draw, grade 2, not a grade 3, a positive Latchman and a positive McMurray's. Next slide, please. So what we feel went wrong in the primary surgery was that the medial meniscus, or rather the ramp tear, was not addressed, which led to micro instabilities. The tibial tunnel, as you can see in the MRI, was quite posterior. And because of this, there was a compounding instability with an unrepaired lamp lesion and a malpositioned tunnel led to progressive laxity. Next slide, please. So here you can see in this, pictures, that there is dense arthrofibrosis in the anterior gutter, which is seen with a few ACL surgeries. You can see in the video how the ACL tunnel is lax. Now, what I'd like to point out is the ACL basically in the femur was quite good. There was a lot of synovialization. It was in the tibia where the uptake had not happened. And as you can see, when we're giving the anterior door, there is laxity, there is continuity, there's not a full tear, but laxity is definitely present. And in the other image, as you can see, there is a type for meniscocapsular separation with retraction. So can we go to the next slide? So what was our surgical technique? Well, we had a 4-step combined approach. We first addressed the ramp with a needle-assisted capsular retrieval and a hybrid suture construct where we used the inside out and the all inside sutures. We did a lateral, when we went in and did a diagnostic, we found that even the lateral meniscectomy, which was done in the primary surgery, was not complete. There was a part of the lateral meniscus which was torn. So it was a partial meniscectomy done of the irreparable white zone tear. We augmented the ACL by taking multiple bites through the ACL stump, like you would do an ACL avulsion. And we just pulled it across and fixed it to the tibia with the hope that it will give us a good amount of stability to the patient. And we did a microfracture overall to increase the bioavailability of stem cells to allow good healing of the repair that we're doing. Next slide. So what was the first step? Well, the first step was basically a posterior-medial portal which was established. In the meniscocapsular junction, we identified a massive ramp tear. The meniscocapsular interface was debrided using rasps, using the needle method, where the needle went from the anterior medial portal all the way to the capsule, making multiple holes to allow vascular access channels. We used the shaver without suction to kind of irritate the capsule behind to allow blood supply to take place. We passed an epidural needle through the posterior horn of the medial meniscus to engage and elevate the retracted capsule. 3 all-inside sutures were placed posterior centrally and from posterior central to posterior medial, which is basically we are moving from centromedial all the way to the medial aspect. Augmentation with inside-out sutures were done for additional meniscocapsular compression, and we found a stable hybrid repair construct, which was confirmed on probing. So if you can see the video here, we have the completed hybrid repair. And if you can see how stable it is now, the capsule is not moving and the meniscus is pretty much stable. Next slide, please. So the difference between Pirelli et al. And our technique was, while they used their ramp repair with a bent spinal needle, we used an epidural needle. They used the tissue reduction from anterior portals while we used the posterior medial portal. And we used, our technique was for a severely retracted type 4 lesion with a chronic injury where the capsule quality was also not great. Next slide, please. So for the ACL graft, what did we do? We basically took a 1.5 mm fiber tape, which was passed through the graft substance using the suture passing device. Sequential bites of the mid substance were taken. An anatomical tibial jig pointed was identified anteriorly. A beath pin was inserted using the ACL jig for minimal diameter tunnel because we did not want convergence. We took a spinal needle with Ethlon, used it to shuttle the fiber tape through the tunnel, and we tensioned it and tied it across on the tibia using a suture button. So this is the, as you saw the final video, how much laxity was there. This is the final video after tensioning of the ACL. We found it was quite strong, and we found that the anterior drawer had reduced from grade 2 to grade 1, or rather grade 0. Next slide, please. So how our technique differed is we used a 1.5 mm fiber tape. We did an in situ augmentation where the graft was left intact. We did not do a revision ACL. We used a minimal 2.5 mm tibial diameter with ACL jig. The ramp lesion was repaired to give it more stability, and a posterior tibial tunnel was addressed. And the graft age was around 4.5 months in our technique. So fiber tape, we have found, provides broader load distribution, greater construct stiffness, and avoids cheese grating phenomenon associated with thinner suture materials, especially in tissue which is chronically injured. Next slide, please. So this is the surgical video, and I will just go through it a little quickly. So that this is the ACL that we saw, that the quite a lax ACL which is there. I wouldn't say it's a complete tear; it's just a ACL laxity which was there. Now, Dr. Bharat, could we go to the ramp part of it? So you can see I'm using my shaver blade and I'm trying to, find the area, is there a complete tear or not? And we find that the basically wholly intact is just lax, probably because of the posterioralization of the tibia. So we'll just show you our ramp repair technique. If you could bear with me for a minute. So what we've done is you are using the needle to kind of lift up the ramp to see exactly how much of the capsule is there, and you can very clearly see that there is a ramp needle, tear, which is the type 4 meniscocapsular separation is there. We made a posterior medial portal. We've used the small artery forceps to pick up the capsule, and we found that it's a pretty big tear. So what we decided that we put a cannula in so that we get more access to lift it up. So what we decided was that we're going to go with our repair from central to medial rather than from medial to central. And so we're using the shaver to kind of prepare. And I believe that preparation is very, very important, because for the healing, just depending on the sutures for it to heal really doesn't work. So here we've taken an epidural needle, we've taken a bite of the capsule, and we've tried to kind of, hinge it on the meniscus, so that it becomes easy for us to get access to the posterior medial capsule while we're putting all inside or inside out sutures. So once we do that, once we've hinged it's kept there as a temporary sort of a K-wire, which we use for reduction for, let's say, comminuted fractures. It's really not going to serve a permanent purpose, but what it did was it helped us lift the capsule and keep it there while our instrumentation of all inside was going from posterior central to posterior medial. So then we started taking bites from the capsule all the way to the posterior part of the meniscus, and we took multiple bites from excuse me, from the posterior central to the posterior medial part. We first went in with our all inside stitches, which we found gave us a good lift, and then finally we augmented it with inside out stitches so that we had a good capsular augmentation. So this is basically our technique, where we are putting multiple stitches after lifting the capsule. And the final picture, Dr. Bhatt, could we have it a little forward? Yes, thank you. So if you see the final picture, you can see that the ramp was quite stable. The medial meniscus was quite stable. And we've used a technique where we've tried to put as many sutures as we can so that we get a good stable construct. And there it is. We're quite happy with the repair there. And the ACL basically augmentation was pretty basic. Like I showed in the previous slides, we just took multiple bites from a suture lasso or a first pass. When we used it like an ACL avulsion technique, where we just pulled it across and fixed it with a 2.5 by drilling a 2.4 mm Beath pin anteriorly to the tibia and just pulling it across and giving it tension because there was no complete tear. So we didn't want to do we didn't feel that a revision ACL surgery would be required. And of course, this was a risk. This was something that we had read in a couple of papers. We were taking a risk with that. And we had explained to the patient that, both options were given. And the patient also was willing to accept this particular technique, provided that we got a good result from it. But after doing our repair, we were quite happy with the stability that we got. So we decided to go ahead, and close up the patient post the repair that we've done. So you can see my tibial jig is a little anterior. My 2.4 mm Beath pin has come. I've removed that. I've put a spinal needle. I've passed a passing suture from the spinal needle, and I've shuttled the fiber tape threads there. And I've just pulled down the graft and I've just given it a bit of tension, which I felt was required because the whole concept was that if we get a good ramp repair, which is giving it stability, and we just give it a little bit of tension to the ACL, then it should work. And in our case, touch wood, and thankfully it did. So there you can see the shuttling happening. So at 2 weeks, we had a good range of motion for the patient. She had come to us with a lot of medial-sided pain and laxity, but she was pretty fine, better than she was doing at her primary surgery. At 3 weeks, she had achieved full range of movement. The anterior draw was negative. Full weight bearing was commenced. At 5 weeks, we administered an intra-articular PRP. And at 10 weeks, this was probably the most surprising part, that she was gymming, swimming, jogging, cycling. In fact, she also went for a marathon around 3 months later, and she continues to be pain-free and she continues to do really well. So I think the key comparison versus the primary surgery was that the recovery after this graft procedure was markedly superior to the primary reconstruction. The patient achieved functional milestones that had not been possible in the 4.5 months following the index ACL surgery. Can we go to the next slide? So the advantages over the full revision was we preserved the graft, there were no tunnel issues, there was reduced operative time, there was faster rehabilitation, and we did address the root cause of ramp repair. Could we go to the next slide? Of course, there are limitations to this procedure that we did. It's a single case report. There was a short follow-up at 10 weeks when we did it, but now we've had around 3.5 months of follow-up in which the patient is still continuing to do well. We cannot isolate the contribution of each concomitant procedure, and long-term objective stability data is still pending. I believe it is indicated when the graft is intact but functionally lacks, and there is a comorbidity associated, that it's not just an ACL instability, but also there is a meniscus or a ramp lesion contributing to that instability. I believe it is not appropriate. This kind of procedure is not appropriate for a frank graft rupture. For significant tunnel malpositioning, which do require full revisions, and of course for tunnel widening procedures where a revision in the form of 2-stage is required. Can we go to the next slide? So the take-home message I would have for people listening to this talk would be that you should routinely evaluate your posterior medial compartment. I believe that looking at the ramp lesions should become a part of our diagnostic arthroscopy, because ramp lesions are more often than not still being missed. I think everybody focuses a lot on femur tunnels, but a posterior tibial tunnel placement is an under-recognized cause of persistent laxity. So always assess the tunnel position in the symptomatic post-ACLR patients. I believe the graft preservation augmentation with fiber tape is a viable, albeit a limited alternative to full revision when the graft is intact but functionally lax. And a needle-assisted capsular retrieval, where you can use an epidural needle to kind of hinge the capsule to the meniscus while you do your repair, like a K-wire, like you would put a temporary K-wire to reduce a fracture, can help in severely retracted type 4 meniscocapsular separations where the standard devices cannot reach. Next slide, please. So I thank you all for your patient listening. Thank you so much for giving me this opportunity again. And thank you, Dr. Bharat, for assisting me in this talk.
Actually, nice and innovative. So we'll be definitely. But this is a single case you have done, Dr. Akshay.
Yes, sir. It was done as a very limited procedure because the patient was a female with a very short femur, low demand female. Again, multiple times we had told them about requirement of probably a secondary procedure may be required in terms of reconstruction of ACL, where the patient was not willing. She was explained all those parameters before we went in, and we were prepared that in case this procedure doesn't work or we don't have a good outcome intraoperatively, we would be going ahead with the revision ACL reconstruction. Yes.
Nicely done.
Thank you, sir.
I would say rather a daring decision, actually.
Yeah,
Yes,
actually,
sir.
yeah.
Because so the reason for the primary ACL failure was missed ramp lesion or untreated ramp lesion.
Yes, sir.
Okay, fine. One thing is normally when you do the ACL reconstruction, it tends to stay as a soft tissue graft for 3 months. And
Yes,
then you have a period of ligamentization between 3 to 6 months time.
Yes,
where relatively weak. Now, I'm surprised that the fiber tape helped in restoring the fixation of the graft back to its original footprint area. Maybe
Yes.
a period of ligamentization, I don't know. But even
Yes.
if in that case, what happens during the ligamentization phase, the tendon quality becomes poor, it becomes weak,
Yes.
and
Yes.
then it becomes strong after 6 months when it becomes a complete ligament. So
Yes, sir.
this stage has got both an advantage as well as disadvantage. But
Yes.
you are good enough to come out with a very good result. Maybe it was
Yes.
because it was a female patient with a low demand.
Yes,
Hopefully
sir.
it will be a good one.
Absolutely, sir. I totally agree with you, sir. I would not recommend this procedure for a high demand individual or a patient who's looking to get back into sports. I would still say that the primary objective for doing a proper revision, if required. But again, the whole idea of this talk was to say that, so the ramp lesions are a very big cause of instabilities and post and ACL failures, which is of course being talked about, but also to show that there are certain times when you can get away with just doing an ACL augmentation. Of course, we're looking at areas where we can find indications for this procedure where it can become a standard procedure or on its own, but it does require a lot more research.
Yeah, correct. Ramp lesions were frequently missed lesions, I would say 12, 13 years ago, because accessing the postmedial aspect, we never had it as a routine procedure in diagnostic arthroscopy. It was brought to light by Leprard and his team, and that's when we understood that we have to do a routine diagnostic scopy to that area and have a look at it. And it's a very important factor for residual instability even after ACL fixation. So thanks a lot for highlighting of that important point. Thank you very much.
Thank you,
sir. Do we have any more questions? Anybody on the panel wants to ask anything? Okay, Dr. Akshay, nice to see you on this forum. Dr. Akshay, able to hear me?
Yes, sir, I can, sir.
Yeah. Just continuing the theme of what Shyam sir was saying. I mean, it's a very daring step to do. I mean, you would think twice, especially, I'm not talking about the ramp, about the ACL tensioning maneuver that you have accomplished. About the ramp, do you routinely use this epidural thing in an acute scenario also, or do you use a lasso from the posteromedial portal and take a bite? Why did you go for this? Is it like a special scenario in this case?
Yes, sir. So we, in an acute scenario, sir, where the capsule is inflamed, while there is a little bit of a damage here, what we found was initially I did try with a lasso to kind of lift it and put it up.
Okay.
But what I was finding was that the lasso kept on tearing the capsule. So it was so thin and friable that I realized that I was causing more damage. So just like you would do as a K-wire in a fracture fixation, I just used the epidural needle to kind of hinge it on the meniscus. And then my first bite was in the capsule inferiorly, and then I was trying to just lift it up and get it to the, get a good bunch of capsule to the meniscus. And we kind of did end up succeeding in that procedure. So like you said, sir, we thought about it 4 or 5 times, not just 2 times, 4 or 5 times before doing it. We did debate a lot on table before and after. But thankfully, the patient is doing very well. She's running marathons now and she's very happy. And the main thing is that she's feeling that, the posterior medial pain and the instability that is there is completely gone. So it's also given her a lot of confidence. We did definitely counsel her that a lot of rehab would be required. because, of course, revision surgery requiring a lot of muscle strengthening. But she's been following that up, and so far, we've got a good result, sir.
Fantastic, Dr.
Akshay, Bhupesh here. Can I
Sir,
quickly ask you a small question? So,
please, sir.
what is the reason this failed in the first place?
So I believe it was the ramp here, sir, which was missed.
Okay, and also slightly posterior tibial tunnel.
Yes, sir.
What is the slope of this patient?
To be honest with you, sir, did not calculate the slope.
Okay. So
Yes.
I also think it is the ramp and then the slightly posterior tunnel. But
Yes,
just
sir.
for completion's sake, I think we should have a protocol in mind whenever there is a failed ACL. We
Yes,
should
sir.
have a list of things that we should always check before, trying to do things. So I would also advise to, take long leg X-rays and check for slope, because
Yes,
it's I'm not saying slope is the reason.
right, sir.
Might not be the reason, but when the patient has now come to us for the second time,
Yes,
so we
sir.
have to be extra careful.
Absolutely,
Even
sir.
if the slope is high,
Yes,
in
sir.
primary ACL, we don't do slope correction. But we
Right, sir.
counsel the patient that there is a chance that things can fail because you have an inherently high slope.
Yes,
And
sir.
more so importantly, we have to talk about it to the patient on the second sitting.
Yes, sir.
But your innovative technique of retensioning the graft is what I would call, with small bead pin holes, I think is fantastic. Novel idea, I think, and it has worked. So and because the patient is doing well, I don't think slope is the issue here, but just for academic reasons and for completion's sake,
Yes, sir.
I think we should always look into it in a second scenario.
I really appreciate that, sir. Thank you,
One
sir.
more technical tip which I would like to give with respect to ramp lesion is
Yes, sir.
when I find that the lasso is tearing through the capsule,
Yes, sir.
what I generally do is if MCL pie crusting is not contraindicated, I
Yes,
will
sir.
adjust it properly, open up the medial joint space.
Yes,
And
sir.
you have the knee scorpion which is available. So you can
Yes, sir.
over the meniscus, take a bite in the capsule, and then you
Yes,
get another bite over the meniscus also, and then you
Yes,
can tie the knot from postomedial portal. That's one more technique, which which does not cause much damage to the capsulomeniscal junction area.
Thank you, sir. I didn't think of that, but you've given me another, weapon in my armor, Turin. Thank you so
What
much.
was the difficulty with lasso? I didn't understand the lasso.
Sir,
The shoulder lasso, is it?
Yes, sir. The shoulder lasso. We didn't have we had the shoulder lassos available to us. When I was trying to take bites, sir, it was tearing through the capsule. So it was not giving me that the hold that I wanted while I was trying to do the ramp repair, sir.
Okay.
We have ramp specific
ramp lasso is very useful because it is basically a needle which is bent.
Yes,
The
sir.
ramp lasso. So it does not make a big puncture through the postomedial capsule, and
Yes.
usually you get beautiful bites through that.
Absolutely, sir. I
And
found out about that after I did this case. So I do now use ramp lassos for
before
my...
ramp lasso came, and then we were just starting to do this.
Yes,
I
sir.
also used to struggle with the shoulder lassos.
Yes, sir.
One trick here is just a trick. It can be useful sometimes to anybody.
Sure, sir.
Taking the first bite through the capsule sometimes is very difficult, as you said.
Right,
Because
sir.
the capsule never stays where you want, because it's a very lax capsule and it keeps moving.
Right, sir.
So instead, what you can do is you can take the bite through the opposite side lasso through the meniscus first.
Understood, sir.
And once you take it through the meniscus first, anterior bite through the opposite side thing,
Yes, sir.
the tip of the lasso is now under the postomedial capsule.
Right.
And then that is relatively easy for you to puncture and come out.
Got
So
it.
get
Got
what
it.
I'm saying?
Yes,
Not
sir.
through the capsule first and through the meniscus first.
Meniscus first and then capsule.
Yeah, sometimes that works. You should never try to take the bite. You should only try to twist the lasso and it will sometimes come out. Because your bigger ramps are falling down and it is difficult for you to take the bite from the side. I've tried it once, but now I use the ramp lasso, so it is very easy.
Got it, sir.
If somebody is having only the lasso of the shoulder and we get stuck, try the other way out.
Thank you, sir.
So I think we are coming to the end of the discussion. Dr. Vinay or Dr. Prathamesh, do you want to conclude the session? And Dr. Akshay, you can unshare your screen.
Thank you, sir.
Dr. Vinay, you're there? Dr. Prathamesh, sir?
Yeah.
Sir,
Yes.
would you like to conclude the session? We had an excellent session
Yes.
of
So
1 hour.
it was an excellent coverage of topics. So we could discuss knee, shoulder, and some innovative ideas by Dr. Akshay. Dr. IPS, as usual, was very good and meticulous in a long series of 70 cases. So 270-degree repairs. So overall, very nice presentations by everybody and a good get together after a long time for me as well, meeting all the friends.
Yes. So thank you, Prathamesh sir and Dr. Shyam and all the EC members who were there. Rajiv sir, Sundar sir, he took time to come in. Dr. Bhupesh sir and all the other seniors who came and were a part of this program. Thank you, everybody.
Thank you. Thanks a lot.
Thank you.
Thank
Thank
you.
you.
Thank you.